Hi, this week in Clinical Research Seminar, we're going to talk about different types of observational studies. First, I wanted to talk a little bit about some of the dangers of correlation and causation. So as you see in this graph, looking at the USDA and CDC data sets, there is a distinct correlation between the per capita consumption of cheese in the United States and the number of people who died by becoming tangled in their bed sheets. Here you can see that there was an increase over time from the years 2000 to 2009 in both the number of pounds of cheese consumed by each American on average, which ranged from 29.8 pounds per year up to 32.8 in 2009, and the number of people who died by becoming tangled in their bed sheets, which increased from 327 in the year 2000 to 717 in the year 2009. And the correlation was a 0.94. It's a very high correlation between these two. Next, consider that the divorce rate in Maine correlates with the per capita consumption of margarine. So Americans consumed anywhere from 8.2 to 3.7 pounds of margarine per year from the year 2000 to 2009, which was a decline. And during that time, the divorce rate in Maine dropped from 5 divorces per 1,000 people to 4.1 per 1,000 people. And this was a very close correlation of 0.99. So you have to ask yourself, do we think that cheese consumption is leading people to die by becoming tangled in their bed sheets? Or if divorce is somehow associated with the rate of consumption of margarine? Probably not. But correlations such as these can demonstrate the dangers of association studies and underscore the fact that association studies really need to be well designed and executed in order to avoid spurious associations such as this. So this week we're going to talk about some of these common observational study designs and how to be a good reader of them. These study designs include cross-section studies, cohort studies, and case control studies. A cohort study, as we discussed in advanced study design, is a group followed over time. This can either be retrospective or prospective. An example is where an investigator examines a cohort of women yearly for several years, observing the incidence of heart attacks in hormone users and non-hormone users. A cross-sectional study is a group examined at one point in time. In this study design, an investigator, for example, would look at a group of women one time, observing the prevalence of a history of heart attacks in those using hormones and those that did not use hormonal contraceptives. A case control study would look at two groups based on the outcome. So she's interested in the outcome of heart attacks, so the investigator would look at a group of women with heart attacks and compare them with a group of healthy women, asking them about whether or not they had hormone use. In an experimental design, an investigator could evaluate this by randomizing groups to the intervention. So there would be two groups created by a random process with a blinded intervention. She would assign women to receive either hormone or placebo and follow both treatment groups for years to observe the incidence of heart attacks. Why would one pursue an observational study? For one thing, they can be cheaper than conducting a randomized controlled trial. Secondly, they also may be faster. You can use existing data and examine long-term effects, often retrospectively or prospectively, but maybe with less expense and time. These generally can be thought to be hypothesis-generating, since you really can't conclude a definitive cause-effect from such studies, just as I demonstrated in those previous slides about correlation. Sometimes these studies are preferable because experimental studies of a particular issue would not be ethical. For example, it wouldn't necessarily be ethical to randomize subjects to smoke or not smoke in a clinical trial. Cross-sectional studies are the most familiar to us as surveys. In a cross-sectional study, people are studied at a point in time. Follow-up is not generally part of the cross-sectional study, though sometimes a cross-sectional study serves as the baseline for a cohort study or an interventional trial. Sometimes cross-sectional studies are carried out repeatedly in the same population so that the results can be compared across time and changes observed. However, the basic cross-sectional study design is simply a single survey. Cross-sectional studies measure prevalence of health conditions, exposures, and other characteristics of the population. They provide a snapshot or still life portrait. The cross-sectional design can be used to measure any factor that can be reported by respondents or assayed non-invasively and does not require follow-up to assess. Cross-sectional studies are the source of most of what we know about the population, other than vital statistics. You may become familiar with some of the national surveys in advanced study design and other courses in our program. When interpreting cross-sectional studies, one must keep in mind a number of considerations. First, these studies provide data on prevalence, not incidence. If incidence is our real interest, as it generally is for etiologic research, prevalence may not be a good surrogate. An important problem with prevalence data is that cross-sectional studies include only survivors and stayers. Rapidly fatal conditions will be generally underrepresented in a cross-sectional study compared to the total number of people who are affected during a given time interval. Also, conditions and characteristics associated with out-migration will also be underrepresented. In addition, for associations where causation is a possibility, it may be difficult to determine whether the cause preceded the effect. Which came first? The exception to this is genetic factors, where clearly we know that a patient's genes may impact what you see develop later, although other factors such as environmental factors can also play a role. Note that the incidence information is not available from a typical cross-sectional study, as we discussed previously, except it can be reconstructed from historical information. An example of such a reconstruction is something called a quit ratio in the smoking cessation literature. The quit ratio is the incidence proportion of quitting smoking. It is calculated as the ratio of ex-smokers to ever-smokers. For the quit ratio to represent the actual incidence proportion of quitting, mortality and migration prior to that age must be minimal or unrelated to smoking status, and smoking initiation must be rare in the relevant age range. Another type of observational study design, one that you may see commonly in the literature, is prospective cohort studies. Cohort studies begin with the identification of a population and assessment of the exposure. For example, lipid or blood pressure levels in a population, and then following them for cardiovascular events. The temporal sequence to these events is generally known. It can be difficult to ascertain the effect of exposure in these types of studies. There can also be many differences between the exposed and unexposed groups, in addition to just the factor that you're measuring. These are called confounding factors. We'll talk about these a little more later in this presentation. You can adjust for some of these known risk factor differences, and that can help control for these factors in your analysis and allow you to know if the factor that you're really interested in is an independent predictor of your outcome. However, there can be unknown factors that you're not accounting for between your exposed and unexposed groups, and these will never be adjusted for. These studies also have to address the issue of follow-up. Is a planned follow-up duration reasonable and practical for the study question and the sample size utilized? For example, when assessing the effect of a new painkiller on the degree of pain relief, this may only require 48 hours of follow-up. The effect of a cholesterol medication on mortality may require more like 5 years to see. So you have to ask if the study followed patients for the appropriate duration of time to measure the effects that they were wanting to see. There are lots of well-known large prospective cohort studies that have been completed in the United States and around the world. One of the best known is the Framingham Heart Study, which helped identify many of the factors associated with cardiovascular disease. There's also the Cardiovascular Health Study, the Multi-Ethnic Study of Atherosclerosis, and a Nurses' Health Study. If you just do a PubMed search for Nurses' Health Study or go to the Nurses' Health Study website, you'll see hundreds and hundreds of publications with really important data that have come out of the Nurses' Health Study. There are several advantages of prospective cohort studies. First, For common diseases, you can generate a very large sample size in a relatively short period of time. These studies also have the ability to follow persons from healthy to disease states. And this is a great example of that was the Nurse Health Study that enrolled tens of thousands of nurses and then followed them for years and years and decades to see what were predictors of them developing things like cardiovascular disease, stroke, MI, and death. You can assess the temporal relationship between the risk factor measures and the development of the disease. These studies allow a direct estimate of risk, such as cumulative incidence, and a rate of disease occurrence over time, or the incidence rate. This is in contrast to a cross-sectional study, really where you can just see prevalence. These studies are also an efficient means of studying rare exposures. For example, lead can be studied in a situation or a cohort study such as this, in comparison to case control studies, which tend to be better for rare outcomes. These also allow the investigator to assess multiple outcomes of a single exposure. They also allow the investigator to avoid recall bias and survival bias, because you're not asking patients about their exposure, rather you're collecting their exposures over time, so recall is not much of an issue. And all subjects are included. Finally, these are the best observational design for cause and effect relationships. Some of the disadvantages of cohort studies are that they're expensive due to the large sample size that's often needed to accrue enough events. These often require large sample sizes, especially when the outcome is rare, and a rare outcome would be defined as less than one event per 1,000 person years. As mentioned in previous slides, it can take many years to develop the disease of interest, and this makes more time and expense necessary to conduct such a study. There can also be problems with attrition or loss to follow-up of patients. There can be bias due to loss to follow-up if patients move away or somehow just don't return for their follow-up visits. It's possible that individuals who leave the cohort prematurely may have a different baseline risk than the members who continue to complete the study. And it's possible then, with this attrition, that the study may not be generalizable to the original target population. Causal inference is not definitive, as it is difficult to consider all of the potential confounders, as I mentioned previously. You can't collect data on every possible variable or risk factor or association that a patient might have. That would lead to an extremely expensive and costly study, as well as reams of data that may never even really be used. And statistically, you can't really evaluate hundreds and hundreds and hundreds of risk factors with your outcome. You probably won't have enough events to do that. So investigators typically narrow the list of variables collected to those that have a biological plausibility. However, this then means that there are things that are included that could play a role, but that we never really assess. Also, there can be differences in the quality of measurement of the exposure or the disease between the exposed and non-exposed, and this can introduce what we call information bias and distort the outcome. This is because some individuals may pay more close attention to their exposures as well as their medical care as they develop the disease, whereas others who are healthy might not be paying attention to those issues. As we talked about last week, how strong is strong when we talk about associations in observational studies? A cohort study like this might report a relative risk. And as we discussed, a relative risk of 1 means basically there's no association. But down in the 1 to 1.5 range, you have weak or modest associations. As you get closer about 3, you're getting some moderate to strong associations from 3 to 8. And above that, very strong, dramatic, and overwhelming associations. If you recall, these types of associations, again, could be impacted by the study sample size. So you need to look at the confidence interval around this relative risk, as well as the absolute number. And if the confidence interval is very wide, that may be overinflated in terms of your relative risk value due to low sample size. So you have to interpret these with caution. Case control studies are the most frequent type of epidemiologic study. They can be carried out in a shorter time than some of these other study designs. They also require a smaller sample size, so they're less expensive to perform. Case control studies are sometimes the only practical approach for identifying risk factors for rare diseases. where follow-up of a large sample for occurrence of the condition would just be impractical. There are three main types of case control studies. There are case-based, population-based, and nested case control. Case-based case control studies have cases that are identified at the time of diagnosis at one or more clinical sites. Controls for these are usually other patients at the same clinical site. The advantages of the case-based case control study are that the controls are readily accessible, as they can be drawn from the same clinical population, and they'll have medical records that are readily available. But the disadvantages are that these controls aren't coming from the general population, so there can be selection bias, in that these are people already presenting for medical care, for example, and they might not be generalizable to a larger population of subjects with the disease. Population-based case control studies eliminate this type of bias by gathering their cases from the community. Controls are residents of that same community. The advantages here, as I said, are less selection bias, and the incidence of the disease and the number prevented in the population can be calculated, since this represents a population-based estimate. However, the frequency of risk factor in the controls can also be used to estimate the prevalence of the risk factor in the population, and you can calculate a population attributable risk percent, which is another advantage of these studies. But population-based studies can still be biased if the factor under investigation still impacts the likelihood of participation or diagnosis. Nested case control studies are derived from a cohort study or randomized trial for their cases, and then controls are a random sample of other subjects from the larger study. Advantages of a nested study are that they avoid selection bias, and they're less costly than a prospective study to perform because the data that you're using have already been generated. The disadvantages of a nested case control study are that they require a well-designed larger study. Some examples of this would be an incident case, such as those having cardiovascular disease, with a matched set of controls. This would allow you to examine the association of a risk factor that was measured sometime before the development of the outcome of interest. However, this may not provide equivalent estimates. In case control studies, selection of the appropriately matched control group, for example, hospital versus healthy community controls, in consideration of potential confounders is crucial. These studies also rely on historical information to obtain exposure status and information on confounders, and these are not necessarily always readily available. For example, if you're trying to collect information on smoking and whether or not that's associated with the development of a disease, smoking information is not well captured in a lot of old medical records. In the newer medical systems, they're better at capturing this data, but looking back over time, it's very difficult to find information on smoking or alcohol exposure into the general patient population. With a case control study, you also cannot determine for sure whether exposure preceded development of disease. And it's difficult to identify all the differences between cases and controls that can be statistically adjusted for, just like in those cohort studies that I mentioned. Case control studies do have advantages, though, and as mentioned, they're the most efficient design for rare diseases. They require a much smaller study population than cohort studies. You can avoid the logistical challenges of following a large population over time, and allow more intensive evaluation of exposures in cases and controls. These will allow for calculation of an incidence rate. They can yield a valid estimate of the incidence rate ratio derived from a cohort study if incident cases are studied and controls are sampled from the risk set of the source population. This is a specific concern and issue, and one that needs to be considered if incidence is something that you're trying to determine. Disadvantages of case control studies include that they do not yield an estimate of the incidence rate or cumulative incidence, typically, unless special methods are applied, since the denominator for these measures is not defined. They're also subject to recall bias if the exposure is measured by interviews. Recall of exposure, again, as I mentioned previously, may differ between cases and controls because people that are sick might remember things more clearly or more consistently than people that are healthy and who don't pay attention to the types of exposures that they've had. This can be minimized if historical records are available that detail the types of exposures that you're looking for. It can be difficult to choose the appropriate source population, and so this could contribute again to selection bias. These also can, while they might be the best study design for rare diseases, they might not be an efficient means for studying rare exposures, where less than 10% of your controls are exposed to the risk factor of interest. You may need very large numbers of cases of controls to detect the effects when you're looking at something like a rare exposure. Some of the sources of bias and error in case control studies include that the information on the potential risk factor or confounding variables may not be available, as I mentioned, from records or subjects' memories. Cases may be more likely to search for a cause of their disease and be more likely to report an exposure than controls, for the recall bias, as we mentioned. And there can be uncertainty as to whether the agent caused the disease or whether occurrence of the disease caused the person to be exposed to the agent. And there can be difficulty in assembling a case group that's representative of all cases and or assembling the appropriate control group. There are lots of types of bias in these different studies, and there's ways to try to handle this. So selection bias can be due to self-selection, diagnostic workup, where there's biases in whether or not a patient actually gets a procedure to diagnose a condition. A good example of this is deep vein thrombosis, which should be diagnosed with a Doppler, and not all patients with leg pain undergo a Doppler exam. So there's a lot of undiagnosed DVTs out there. So if the DVT was your outcome of interest, there can be differences in diagnosis that then lead to bias in who gets identified with the disease. There can also be withdrawal bias or loss of follow-up, as well as case control selection bias. The problem with all of these types of selection bias are that your sample then does not represent the larger population, and your estimates of the incidence or prevalence of disease in the population will be inaccurate. The ways to control for this are your selection procedures, the setting of the study, careful follow-up and subject selection, and trying to ensure that cases and controls have a similar exposure. There can also be misclassification or information bias, whereas a case is classified as a control or vice versa. This can be due to variation in subjects, variation in observers, technical errors, as well as recall bias. This is due to errors in measurement of the disease exposure, and ways to control this include blinding, the survey methods, mail versus face-to-face, questionnaires with multiple questions to affirm whether or not someone's exposed, timing and accuracy of measurements. And finally, confounding bias, which we're going to talk a little bit more about in the next couple slides, or distortion of the exposure-disease relationship by some other factor. You can try to control for confounding by a randomization, which by its nature would control for confounding. However, randomization is not typically part of these observational study designs. So that's why randomization or randomized trials are a gold standard type of trial to measure cause and effect. You can consider matching, but when you match for a particular risk factor, this removes the confound from the analysis, so you can't really evaluate it any further in its role on your outcome of interest. In the analysis phase, you can do things such as stratification or a multivariable analysis to control for confounders. So a confounder is a factor that is associated with both your disease and your exposure, and is somehow distorting the relationship between exposure by disease or influencing this relationship. So it's important in any observational study that they consider potential confounder and control for these in both the design and the analysis. Risk factors don't usually happen in isolation except in a controlled experiment. So most settings would have confounders. An example of this is that breastfeeding has been linked to a higher IQ in infants. But this association could also be due to confounding by socioeconomic status. Women who breastfeed tend to be better educated and have better prenatal care, and this could explain a higher IQ in their infants. So when reading and evaluating some of these observational studies, I wanted to go through a few things related to internal and external validity. When you look at incidence or prevalence studies, external validity can be evaluated by looking at the sampling of subject by the investigators, how sampling bias may be assessed, estimating sampling bias, looking at the exclusion rate from this study, looking to see whether or not they considered sampling bias in their analysis and flow of subjects. What happened to subjects? Did all subjects complete the study? Did some get excluded, and if so, why? In terms of internal validity, you want to see that there's a source to measure the outcomes, and what was that source? How were outcomes defined? How were outcomes measured? And what were the outcomes in different racial, ethnic, age groups, or gender subpopulations in the study, and how outcomes were reported? Looking at studies of risk factors, the same external validity measures apply. We're looking at the sampling bias, we're looking at the exclusion rate, and the flow of subjects in the study. In terms of internal validity, we're looking at the outcomes again. How are they defined? How are they measured? But we're also looking at the confounding factors, loss to follow-up, if exposure status was masked, what statistical analysis they used, the appropriateness of these models, how they reported their tested hypotheses, precision of the estimates, and as I said, the confidence interval around those estimates of either odds ratio or relative risk, and the justification of the sample size of the study. Major flaws for these types of studies in terms of external validity would include sampling in a clinic for the study that would be interested in measuring incidence in the overall general population. Again, as we suggested, if the clinic is the source of both the cases and controls or the cohort, that may not necessarily reflect the incidence in the overall population. If the controls come from a different population as the cases, that can be a problem. If you have a response rate of less than 40%, that can be a problem. If there's exclusion of more than 10% of eligible subjects from the analyses, then you have to question the generalizability of the study. And if the reasons to exclude a subject from the analysis is different for the exposed and non-exposed, this should raise a red flag. In terms of internal validity, the severity of the outcome can be relevant, but if it's not assessed in the study, that's a problem. If non-valid methods were obtained to measure the outcomes, exposure, or confounding factors, or different methods to measure the exposure was performed in cases versus controls. Or if there were no strategies to reduce bias, this indicates a problem. There are also some minor flaws. In terms of external validity, if random sampling was restricted to a geographic area, if they used a convenience sample, or the authors did not assess sampling bias or address it in the analysis, and sampling of the controls was from healthcare-related sources. As we discussed last week, one of the studies that we looked at included controls that were healthcare providers as opposed to the general population. In terms of internal validity, if outcomes were reported by proxy, this is a problem, or like a surrogate measure, for example, that could be a problem. If the data were obtained from medical records or an administrative database, this could be a problem, but is commonly done, so just the methods really need to be evaluated. If there is a subjective judgment of reliability, or if intensity and dose of exposure might be important to the nature of the outcome, but was not assessed or mentioned in the study. Finally, I wanted to mention briefly the Strobe criteria. These are posted in the Blackboard folder for this week, and you should read the two articles. One is the criteria, the other is interpreting and assessing the criteria. These criteria were created to standardize reporting of observational studies. They're really aimed for investigators that are publishing their data or designing observational trials, but they're a great guide for people reading the literature for observational studies on important points that should be mentioned or addressed by the investigators when evaluating these studies. So the Strobe criteria go through each sort of section of a paper and tell you what should be in that section and how it should be reported. For example, for participants and the flow of participants, they should report the numbers of subjects at each stage of the study, the number that were potentially eligible, the number that were excluded, the number that completed follow-up and were actually analyzed. Then they should give reasons for non-participation at each stage of the study and use a flow diagram. We do that for the research project course with the subject accountability slide, where we show how subjects were excluded from any given study and what happened to them. So these Strobe criteria are great to try to standardize reporting of these studies and help you evaluate them. So make sure you take a look at those. So in summary, observational studies can be useful for generating and exploring hypotheses. They're often not the best way to determine a cause-effect relationship, but they can suggest an association that could then be followed up on in future studies. These studies require careful study design with attention to confounders as well as loss to follow-up issues for, say, a prospective cohort study. And the reader must assess carefully the internal and external validity of these studies and see if they adhere to best practices.